You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Welcome to Fertility Docs Uncensored. We are so excited to be back here again in the studio recording. Ladies, it's so good to see you again.
Hello.
Hi. So we've
Hi.
got Carrie Bedient here with Fertility Center Las Vegas. How are you doing?
Hey.
Oh, there's your fun
How are
little,
you guys?
Fun little hey. We've got Susan Hudson here with Texas Fertility Center.
Hello.
And we have got Abby Eblen here with Nashville Fertility
Hi,
Center.
y'all.
Hi, y'all. I love that.
I don't really say y'all that much, but you know.
You know, and Abby was talking earlier about wanting to get rid of that Southern drawl. I love it.
You know,
Isn't it?
I heard that actually y'all is becoming a Pan-American statement because throughout the last few years, y'all is considered more of a, instead of you guys or the you that makes everybody confused, y'all is
Inclusive.
And so y'all is actually spreading
Interesting.
to areas that it previously had not been.
I moved from Texas to Connecticut when I was younger, and I swear I got the y'all beat out of me in Connecticut. I kid you not. Like, I got made fun of so hardcore.
Apparently, it's going north.
That's frustrating. It took me a long time to, like, get it out of my system.
I will say that you can kind of tell when somebody's trying to pretend like they're saying y'all in the correct way, because y'all means you all, a whole group.
Right.
And sometimes people will refer to y'all as one person, and that's incorrect. That's
Right.
the incorrect way to use y'all.
And,
Well, you know
and
what?
you need to put the apostrophe in the right place.
Absolutely.
You do. And you know what the plural of y'all is?
No.
It's all y'all. I mean, that's what it was in Atlanta in fellowship. I mean, it's all y'all.
It's interesting, though. I say you guys a lot now because I learned to not say y'all anymore, but I do feel uncomfortable saying you guys because, like, I say it to you guys, and you guys are a bunch of females. You're not guys, so it is. That's good. I'm glad it's spreading.
This is why y'all is cool.
The more polite way of saying you guys would be you people, which sounds even worse.
That does
that does sound worse.
Yeah.
You people. Yeah, that would be weird. So, Carrie, you had a hot date last night, right?
I did.
Fun.
I did.
At a hockey game?
We went to the Vegas Golden Knights game, and granted, my husband and I did have a small little third wheel in the form of our 6-year-old daughter, who held her own until 10 o'clock at night without more than probably 3/4 of a meltdown, which was well earned somewhere in the middle of the second period. But it's great. It's such a spectacle. And I know, Abby, you guys are hockey fans in your house too.
Yeah, and you know, I never thought ever in a million years that I would be a hockey fan until my son started playing hockey about 3 years ago, and I started having to learn the rules. And then, of course, the Nashville Predators ended up being in the Stanley Cup playoffs a couple years ago. And my son happened to be at scout camp on that particular Sunday night. And so I ended up going to the final game. Never in a million years was it on my bucket list
You got to go
see
to
the
a
Stanley
final?
Cup. But I actually saw the Stanley Cup. Unfortunately, it was handed over to the other team, though.
Oh.
It's been so interesting to me that you guys, these very feminine women, fertility doctors, are such fans of hockey. We were talking, you guys,
Oh, yeah.
you guys were talking about it. Like, you get down to business when it comes to hockey.
My husband tells me that I have never been sexier to him than when at a game I jumped up and started yelling at the ref because a penalty that he should have called was missed. I mean, there was hooking, and our guy was on the losing end of that, and that guy should have gone to the box, and he did not, and I was up there yelling, and my husband was just looking at me like I was the best thing since sliced bread.
Yeah, and the thing that I think is interesting about hockey, that it's taken me a while to kind of take this in, because even though I see blood in surgery, I don't like to see blood on somebody's face or somebody get beaten up. In hockey, you can beat somebody up, and probably if you were out on the street, you'd be put in jail for the type of abuse that those hockey players take. Yet you can do it on the ice, and practically nobody even notices that the guy's crawling across the ice with blood dripping from his face. You know, it's like, well, that's hockey. You know, don't play it if you don't want to do that.
Yeah.
You go to a fight and a hockey game breaks out.
Absolutely, yeah. I like that. That's good.
Wait, have you always been a hockey fan?
No, I started when my husband loved the Blackhawks. So it's been 15 years that we've been together. And over the course of time, I've evolved into a huge hockey fan, and it's all his fault. But, you grow up in Arizona and there's not much hockey there. Like, Susan, how much hockey is there in Texas?
Yeah, not a whole lot. I mean, I can honestly say I think I've been to one hockey game ever, and it was not like even a professional hockey game.
Okay, so
it just melts too much.
So we need to take poor Susan, who's been deprived, to a hockey game, a real hockey game.
I'm a novice.
So will it be the Predators or the Golden Knights? I don't know.
It's just like such a different side of you, lady, that I wasn't expecting. Wait, so Susan, do you have like a sport? Is there? I know in Texas there are.
Does.
Texas A&M football.
Oh, okay.
There is no other sport.
Gosh, she's looking at me like, you idiot, of course. But, well, yeah, in Texas they're like hardcore about their football.
Yes, they're
Would you
very
say,
hardcore about
like,
football.
they're more hardcore about like college football than like the NFL?
I think it kind of varies from region to region, but I think you have people who they either watch college football or they watch NFL football. They're not somebody who watches both.
Okay.
There's a line.
Interesting. Well, this has been a really weird start to this.
Yes. Most of the ladies out there, and maybe a few of the gentlemen, are going to be like, what are they talking about? This is supposed to be about fertility.
But hey, we're uncensored, right?
Absolutely.
That's what it is. Yeah, that's the whole. So I want to go ahead and get into what we're going to be focusing on with this episode, because this is such important information, especially for people like me who know nothing about infertility. I'm assuming most of our listeners probably are dealing with infertility themselves and have probably been down the Google rabbit hole, which can go bad real quick, right? And there are just so many myths out there about infertility. I mean, even this morning we were having a conversation at breakfast about the crazy questions that you guys get, or just like the very contradicting things that patients say.
It's hard because there's so much information out there. And unfortunately, as we all know, just because it's on the internet doesn't necessarily mean it's true.
Right. Yeah.
You mean they can put things on the internet that aren't true?
No, it's crazy.
Well, the other thing, too, is nothing ever dies on the internet, like postcoital tests. Those we've not done those for 15 years. And I had a patient last week that came in and said, I just don't understand. I've read all this. Why did you not do a postcoital test on me? Because it doesn't work. That's why we don't do it anymore. We haven't done it in 15 years or more, probably.
Oh man, that must be so frustrating to kind of like. Do you guys get that?
I don't think were you even trained to do postcoital tests?
Probably not.
No, I wasn't either.
Yeah,
But how do you give instructions to a patient of, excuse me, sir, ma'am, can you please go home, have sex, and then bring yourself back immediately afterwards because we're going to do a pelvic exam.
Yeah, within 12 hours,
Yeah.
Fortunately, our technology has improved.
Yes, I'm grateful that we didn't have to.
But that's where the internet doesn't know that. And that's hard, I think, as a patient to kind of screen that kind of information and feel like if your doctor is really on track and doing the right test, or if your doctor has really failed to do some monumental important test. But it's not the postcoital test.
Or if somebody is still doing testing that's potentially out of date.
Right.
So it's important to kind of have that sweet spot.
Well, and how frequently do standards in fertility treatment change? Like how often are tests considered like, oh, we've been doing this for a long time, but this is no longer working?
It's a moving target.
Yeah.
It's a moving target. We have our national meeting every year around October, November, and that's kind of the time that new recommendations start coming out and really things get pushed out throughout the nation. I mean, we're always reading our journals and looking at the new research, but that's kind of when things change. And talking about nomenclature, when we were talking about testing embryos, it used to be called PGS and PGD, and now it's PGT-A or PGT-M, and things change in a snap. And the same thing goes for different types of testing. Some things slowly fade away and other things happen rather abruptly.
And that's even true with the general beliefs about fertility. I mean, I can't count the number of people who walked into my office and who have said, I am young, I am fit, my diet is perfect, so I must have good eggs. And, I'm from Las Vegas. My patient population is beautiful. You look at these women and I look at their faces and I'm going, this is going to be a slam dunk. She is 29 years old. And then I look at her chart and she's 42. And it no longer makes a difference that she looks like she's in her 20s, early 30s. Her ovaries know that she's in her 40s. And that makes a huge difference.
And that's even interesting to think about because there is now so much focus on trying to look younger. And I wonder if there's like a psychological component to that, to women who get cosmetic surgery or whatever to look younger and then not focusing as much on their biological clock because they're not seeing themselves age.
Well, I'm the oldest one probably in the room. And so I'll speak for those.
You're 28, right?
Right.
And we're all younger, right?
And I think I've talked to my friends who are my similar age, and externally, I look like somebody, beyond that reproductive age. But internally, I still feel like I'm 29, And I think, like they say, 30's the new 20 and 40's the new 30. Well, that may be true about the way we feel and the way we act and the way we're treated. But unfortunately, like you were saying, Carrie, our ovaries don't care. Our ovaries age, unfortunately. And there really is a limited lifespan. I think a lot of our patients don't realize that lifespan really, that our eggs start to age probably even starting as early as 30 and maybe even at 35 a little more quickly. And then over 40, it's actually, wouldn't you guys agree, it's really difficult for somebody to get pregnant over 40. It's not a chip shot by any means.
It is. And unfortunately, we can't fix eggs per se. We can work with the number of eggs or the quality of eggs women have, but unfortunately there isn't a miracle cure for not having enough eggs or having eggs that aren't of good quality. There are definitely things we can do to help, but women are born with all the eggs they're ever going to get, unlike guys who get new sperm every 72 days.
Right. Well, and that's where egg freezing kind of comes into play, right? It's the benefit.
Is you really freeze those eggs in time. They don't age once they're frozen.
Right, right.
Well, but it's all not just about the incredible inedible egg. Fertility is a dual issue. It's not just the women, because so many women come in and go, oh my gosh, this is me. I did this, I did that, I didn't do this, I didn't do that. And all along, it takes two to tango.
It does. And 40% of fertility cases do have some contributing male component.
How hard is it to get your male patients to go in and do that semen analysis?
We usually try and schedule with the new visit, if he's never had a semen analysis, we usually try and schedule the male partner at the same time. And at the end of my consultation visit, we've talked for 20, 25 minutes, and then I'll say, well, now you're scheduled for a sperm test today, aren't you? And I'll look at him, and he has this horrified expression, and he looks at his wife, and it's so funny to see the difference between the female. She's like, oh yeah, he's going to do it today. And he's looking at me like, oh my gosh.
I have mentally prepare for this.
Exactly.
Yeah.
And sometimes men will even admit, I'm just not mentally, I just can't do this today, So I think it's kind of funny that, women are fully prepared a lot of times when they come in, but it's really terrifying to male patients, I think, a lot of times. Wouldn't you agree that a lot of men
deer in the headlights?
Yes, exactly.
And I've got my whole spiel of, this is not necessarily going to be the most romantic experience, but you know how to do this. It'll be fine. I just need you to not miss the cup. And even if you do miss the cup, the information I'm going to get is going to be enough to get what we need. Which the whole issue of diagnostic tests in general, a lot of times people will come in and they will have this whole battery of testing that we've done to look at their tubes, their uterus, their ovaries, sperm for him, and general health for both of them. And probably one of the more frustrating things for me is to sit down and say, hey, all your testing is normal. And then they look back at me and they go, what? Well, then why am I not pregnant?
Yeah, that's one of the hard things. We live in such an age where we're used to getting on Google and saying, why is the sky blue? And to have really what we call unexplained infertility being your diagnosis is a really, really hard thing for our patients to take in. And the way that I explain it is that if we wrote a book about everything we know about fertility, and then we wrote a book about everything we can test for, that second book is only about half as thick, because even though we have come light years from where we were even just 30 years ago, there's so many things that we just can't non-invasively test. Kind of one of the best examples is people ask, well, have I ever had implantation? Well, if you haven't had a positive pregnancy test, me nor anybody else on this planet isn't going to be able to tell you, because we can't tell what's happening in that time between implantation and when somebody has a period.
And along those same lines, I was thinking about when I was one of our national meetings a few years ago, there was a researcher there who had spent her entire 20-plus year career on what happens in the first 24 hours when the egg and the sperm go together. And so just intuitively, even if you don't have much of a background in science, that, think about all the steps. The sperm has to find the egg. So 50% of the sperm probably go to one tube, 50% go to the other, and half the sperm don't even get there. The sperm has to find its way. It has to get to the egg. It has to bind. And then all these regulatory steps have to happen so that 24 hours later, or actually 12 hours, there's an embryo there. And so there's so many steps that have to happen. What I say is, I think birth is a miraculous process. It's a wonder any of us are even here talking.
Kidding. Well, and the fact that you guys can basically create it, you have my deepest respect. That's what I'm saying. It's truly an amazing thing. What's like the craziest myth that you've all heard about, like from a patient or just in general in relation to fertility?
We get a lot of, how do I select the gender of my child or the sex of my child? And what happens if I eat this, drink that, go into this position?
Sexual positions. That's
Sexual positions
that's a
is
big
a lot.
question.
You're telling me
Yeah.
that having sex upside down is not going to do anything for me.
Afraid not.
It doesn't
Well,
matter.
I mean, it might do something for you,
But it may not help you get pregnant.
but it may not affect your male or female child.
Okay, gotcha. I'll take a breather from that. Okay.
You asked the question, so.
Right.
You ask the question, you get the answer whether you want it or not.
Right. Well, and what about like fertility drugs? Because there's a lot of misconceptions about medications in general, because there's the holistic kind of medication and then there's Western medicine, and it's like these two fields that are constantly at war with each other.
Vitamins are the most challenging question because I really do think probably we're going to find out somewhere down the road that certain supplements or vitamins are helpful. But the problem is, even for those of us who read the medical literature, there's just not big enough studies that have been done long enough to really say for sure that, yes, this really works. And more importantly, to say that this really doesn't have a negative impact. And that's really what we care about more than anything else.
Yeah.
And there's a few vitamins that do have some good information that might be a good thing for us to talk about in another
Absolutely.
episode. But one challenge that we also have is that vitamins and supplements, they're not regulated by the
Exactly.
FDA. And what that means to us is whatever you're taking in that little pill that you bought from over the counter, wherever, for the most part, you have absolutely no guarantee that you're actually taking what you think you're taking or in the quantities that you're taking. So even when we have studies that say CoQ10 is helpful, if you're not taking something that's a quality supplement and have some sort of reassurance of what's actually in your pill, you could be taking a placebo or a sugar pill.
Right.
And I think we've seen a history in medicine too. And I've been around long enough to see the situation where when I was a resident, we thought hormone replacement therapy was great for women. Every woman that went through menopause, oh, you've got to be on this estrogen. It's so good for your heart. And we gave tons of estrogen pills to ladies, only to find out just a few years later when a really big, large-scale randomized prospective study was done by the National Institutes of Health that yeah, there were some people that it was good for, but there were some people that it wasn't good for. And we were actually doing more harm than good in some of those patients. And so that's why I'm a little hesitant to jump on the bandwagon. I think in medicine, it's best not to be the first to adopt, but it's also best not to be the last to adopt. And so I think you really have to look at things with a little bit more rigor, even as a patient, about, is this kind of the Harry Potter school of medicine, or is this really sound information?
Right.
And natural does not equal safe.
Yeah.
I think that's a big problem that I see in my practice is, oh, I'm taking this and it's natural. And it's like, that's great. But there's lots of poisons that are natural too.
Well, and also, is there any regulation on what you can slap natural on? Can't anyone just put like, this is natural on vitamins or something? Because it's not FDA regulated?
It's not FDA regulated, and just in the same way that when you're buying various meat products, for
That's what I
example,
was
over the
thinking.
counter,
Exactly.
Organic, no hormones, all of these different terms, natural and no additives, those all mean different things, and they're not really regulated by anybody.
Right.
And that applies to a lot of what we do too. And so while many patients come to me and say, oh my gosh, I'm worried about the hormones because I'm afraid they're going to give me cancer. Well, number one, these are hormones that your body produces during pregnancy anyway. Your estrogen levels go between 10 and 100 times higher in pregnancy. Nothing that I'm going to give you is going to put you at higher risk than just getting pregnant, no matter how you get pregnant. If it's the old-fashioned way, making a baby in the bedroom versus high-tech, making a baby in the lab, those hormone levels are high, and that's the greater risk. So for people who come to me and say, I'm worried about getting cancer, I'm like, well, you can also be at a higher risk of breast cancer if you don't have a baby at an early age. So there's a ton of trade-offs in there that people don't realize.
And those hormones have been around for a long time. Clomiphene citrate, for example, has been around for more than 50 years. And there used to be information that suggested maybe you might have an increased risk of ovarian cancer if you were on those hormones for more than a year. Well, millions upon millions of women have now taken clomiphene and several other fertility drugs. And, I think it's probably pretty unlikely now that that contributes greatly to, fairly rare cancers like ovarian cancer.
Unfortunately, pregnancy is preventative for most of the cancers that you would be concerned about potentially by using fertility drugs. So it's really kind of understanding that you are weighing your risks and benefits of potentially not trying to have a child or having a child. Either way, you're going to have some degree of risk, but you have to weigh if that's important to you.
So, okay, I have a question about so many things you guys all just said blew my mind. So you're saying that having a baby can actually prevent you from getting certain types of cancer?
So if you have experienced pregnancy, you have a lower risk of things like breast cancer and ovarian cancer as compared to somebody who's never had a pregnancy before.
Unless you're over 35 like I was when I had my first baby, in which case it increases your chances a little bit of breast cancer.
But does it increase your chance of breast cancer because you had the baby over 35 or because you had some underlying fertility issues that didn't allow you to get pregnant till you're 35?
Yeah, so we don't really know that. That's a good point. Absolutely. So I think it's a good point that you have to look at your risk and benefits of everything and choose for you what the best call is, essentially.
I think that kind of goes into even people having questions about, am I increasing my risk of having a baby with birth defects by having fertility treatments? I know that's something that's on a lot of people's minds.
Well, and I've always heard that having a baby after 40, I don't know if this is true or not, increases the risk of the baby having birth defects. Is that accurate?
Absolutely, because remember we said you're born with all the eggs that you'll ever have. And if you remember back to high school biology, those little chromosomes have to line up and those little hair fibers, those spindle fibers have to pull the chromosomes apart. We think some of those spindle fibers break. Too few chromosomes go one direction, too many go the other. And it's just more likely to happen as you get older. Your eggs are just old and they don't divide as well, essentially.
There's no maintenance crew for the egg. When those chromosomes get the set of instructions, it says, okay, it's time to split up now. They're going like, well, screw you. She's been my best friend for 45 years. The hell I am. And then they run away together and you get too many or too few.
But it's also important to know that
similar.
Even if you're in your 20s, that chromosomal abnormalities in embryos are very, very high. Humans are very inefficient at getting pregnant. It really is truly amazing that it ever happens. And so even when we look at how many embryos somebody gets in an IVF cycle, if we're doing chromosome testing and they're in their 20s or early 30s, it's not unusual for half of the embryos to be chromosomally abnormal. And so if you're already starting that at baseline, and now you're looking at somebody who's 40, 41, 42, 43, that number of how many are normal gets to be lower and lower.
Okay.
And I have a question. Do people look at you like you have three heads when you tell them, okay, you're 25 and half of the embryos that we get are going to be genetically abnormal and half are going to be normal? They look at me like, surely you don't know what you're talking about.
They look at me like, well, okay, how are we going to fix that? What are you going to do to make that better? I'm like, well, you have what you have. I can work with what we got, but I am not a magician. I cannot make things come out of thin air, unfortunately.
But the good news is when you're under 35, it's the glass half empty or the glass half full. The glass half full is you're still, half of your embryos are still going to be genetically normal. And if we put back a genetically normal embryo, and this is with in vitro fertilization, if we transfer a genetically normal embryo, that person has somewhere around a 65 to 70% chance of pregnancy.
Wow.
Which is mind-boggling to me that it's that high now. When I started out, it was 30% was the best pregnancy rate in the best patient.
And even if you choose not to do something like IVF with the chromosome testing, the human body is very, very good at selecting which embryos are actually going to implant or make it through to develop a baby. So even it sounds scary that half of your embryos you create in your body are abnormal, but most of those embryos are never going to implant. They're never going to result in a positive pregnancy test. And most that do implant are going to be lost in a first trimester miscarriage.
So on the other side of the genetic testing ball, you've got the patients who say, I want you to test for everything. And we do genetic carrier screening on pretty much every patient who's willing to let us do it. And it's a panel of 274 is the one that we use most often. And in doing that, they're looking at me like, well, why do I need to do this? My family's totally healthy. And that's wonderful, but you just need one out of those two copies to be abnormal, and your partner has one out of those two abnormal, and they can come together in a baby and cause a problem. And so it seems like it comes out of nowhere. And I kind of call them the sneaker diseases because they sneak through under the radar until you get them.
Yeah, I think it's important to do carrier screening because, number one, most of us don't know 3, 4, 5 generations back of health problems. And realistically, most of the things that we're testing for in these carrier screening packages are things that would lead to death in a child. Okay. Mm-hmm. And so when our grandparents, great-grandparents had a child that was potentially affected, they didn't necessarily know what was happening. It was, unfortunately, a child that passed away, and childhood death within, most of the Western world has improved over time. And it was just one of those things that happened. And so it's hard to find these things in family histories. But what we're really trying to do is help patients, when they look at carrier screening, know that they have options. And their options aren't necessarily, do I do IVF to choose a embryo that doesn't necessarily have that condition, though that is one option. If somebody said, we completely understand this, we know that we have a 25% chance of having a child who has some disease, maybe like cystic fibrosis, that could make an important decision-making in what hospital you might deliver, what pediatrician, what subspecialist pediatricians might you have? What type of childcare am I going to need for this child? If I'm a woman who's wanting to go back to work and potentially baby might need to go into daycare at 8 weeks, is that a good idea for my child? So there's all kinds of paths that this information can lead you to, but I think there's great power in that information.
Well, and just to add to that too, they say with those kind of conditions, like for example, cystic fibrosis is a common one that probably a lot of people have heard of, but one of the second most common one is spinal muscular atrophy. And not that many people that I talk to have really heard of that condition. And for a condition like that, it's a neuromuscular condition. The child doesn't reach its kind of developmental milestones appropriately. And so people tend to go on sort of a medical odyssey because their child doesn't meet their benchmarks, but there's nothing really specific to the disease entity. They don't really know what's going on. And on average, I think it takes about 6 years and a visit to maybe 4 or 5 subspecialists to really figure out what is going on with that child. And meanwhile, the child could have been getting some treatment that may have been helpful for that condition. So it's just, if you and your husband both carry the same condition, even if you don't want to test embryos, if you just want to say, well, we just want to try and get pregnant, at least when the baby's born, you're going to talk to your pediatrician about that and the baby can be tested ahead of time.
For sure. Well, and before we wrap this up, this is going to be kind of like a weird question that's opposite of what we've been talking about. What's a misconception about fertility treatment that people think isn't true? I don't even know if there's an answer to this question, but is there like one thing that patients are shocked to learn works or could potentially positively impact their fertility?
I believe one misconception that we see in our practices a lot is that having a diagnosis of infertility actually has nothing to do with intentionally trying to get pregnant. It only has to do with having unprotected intercourse. It has nothing to do with peeing on sticks, watching your temperature monitoring, anything like that. And so exposure is exposure. And so quite often...
What do you mean by that exactly?
So if you're having sex and you're not preventing pregnancy, that time counts.
So even if you've only been testing your ovulation for 6 months, but you've been having sex for years, then
those years count.
Right.
And so people who need to get help should get help sooner than later.
Okay. Was there anything else that...
One of the things is that it's kind of a flip side of the same coin, that treatment never works or that treatment always works. And so, yes, it works a good percentage of the time. No, it doesn't work every time. And one of the biggest things is not everybody who walks into our office needs IVF. Sometimes it's just as simple as timing things out a little bit better, especially for someone who really truly hasn't been trying that long.
And for somebody who's really young, age really makes a huge difference in terms of success. And younger patients tend to do better more quickly with treatments that are not as involved and not as expensive.
Right. Well, and there's so many components to IVF. We're going to be doing a whole episode coming up on IVF, and actually both Susan and Abby's personal journey, right, with IVF.
Right, yeah.
Because that's some information that I'd even like to know about. Because I know there's a lot of different things that fall under that umbrella of IVF. So, well, this has been super informative for me, someone who doesn't know anything about fertility treatment, and I hope it has for our audience as well. Is there anything that you guys wanted to leave off with? Maybe what's some advice that you have? One piece of advice you would give to someone who's considering going to a fertility doctor?
Talk to your doctor, ask the questions. Don't be scared. We're here to help you.
Just make the appointment.
Carrie's very straightforward. All right.
Yeah, I think people are really scared when they come to the office. And, I walk in, I'm 5'2", and, I'm like, I'm not that intimidating, am I right?
But we recognize that patients are scared.
Yeah,
we know that you don't want to be there.
Absolutely.
But we're here for you.
Yeah, wonderful. Well, this has been great. Thank you so much for listening to Fertility Docs Uncensored. Be sure to tune in to our next episode coming out next week. Thanks so much.